Hi everyone, and as you can see, some of the work here is in collaboration with a number of other people, including Francis, who's here today. We decided in approaching this to really think through the solid basis for doing something on the web. And I had previously done a series of trials, largely with Thiagarajan Siddharthan from Sydney, who many of you will know, looking at snail mail interventions for alcohol, and they're remarkably effective. We get strong results, around about half of the alcohol intake reduced on average, 40 to 50%, and well maintained through to 12 months, and it's consistently better than control conditions. And we already know, in terms of the trials that other people have done, that although the college studies that are largely very brief interventions, largely normative feedback sort of interventions, have relatively small results, that the one study that had been done before we started getting into this field with a community sample of people with alcohol problems had found a fairly substantial effect, and not dissimilar to the sort of size that we've been finding previously. But also we did some research funded by Department of Health and Ageing, looking at a similar sort of question to what Dan was talking about earlier today. That is, what are the existing websites like, and how do people react to them? And it was a wide-ranging study, a series of things, including focus groups, which Francis was responsible for, and an online survey, and review of the literature, and expert reviews of existing sites. So I'm just going to talk about a little bit of that today. This was the internet survey data, and people came back to us with the sorts of things that you would expect them to say, that they wanted from a website. They wanted to have, to be able to get around it easily. They wanted open access. They didn't like logging into things. They wanted the right amount of information. Some things give them too much, some too little, and they want it to be easy to understand. They didn't want to download software. They wanted the pages to be interesting, and they wanted it all to be trustworthy. Interestingly, they said they'd probably use a portal, and we drastically need one in Australia, and we recommended that to the Department of Health and Ageing. They have not as yet taken it up, so we'd appreciate your support in trying to get that. They are looking at it with mental health, but not at the moment with AOD. Online tests with self-assessments and feedback, people said they wanted. Downloadable fact sheets, predictably. Systems tailoring information to the user rather than just standard programs. And we did, in the context of the focus group, some observation of free search, which shows that even when we asked people to look at selected sites, they still didn't stay on them very long. They had up to an hour to be looking at these, and they still stayed only for quite short periods of time on the sites. So the implications are, we don't have very long to engage people. If you want to be doing something online, you've really got to do it quickly, and within a program it's really very important that you have a strong initial module, because quite a lot of people will only come once. We need to be providing that screening and feedback without login if we can. Within our programs we try to use self-tailoring at the moment, but we will be using much more assessment-based tailoring in the future, and we actually we don't tell people this is session 1, you can't access session 2 until next week, and all that kind of stuff. They can access whatever they want in the site, whatever order they want, with the pace that they want. So it's very, very much fitting in with the kind of way that people like to use the internet. But we do give them advice that it's a good idea to do things in this particular order, and to have at least a week or two to try something out before they try something new. Within our work, we try to make it attractive and easy to use by minimising the text entry and using lots of icons. Brief videos to explain concepts, more like ads than long things that people will take ages to download, because download time is still an issue. Summary pages that they can print off and refer to, and diary and progress summaries that they can get into easily. So this is what it looks like on the front page. And you can just click on the quizzes there, and anybody can. You can use that to do a K10 or an audit or whatever yourself with your clients, or get them to do it at home. And get into the programs there. There's a media room thing for sharing YouTube videos that we did, and we had them on TV as advertising as well. The resources are fact sheets and other things that you can download here. When you're in the programs, there are also MP3s and things. And Get Help, of course, is showing you where you can get help quickly, and alerting you to things like suicide risk. Within the program, we've got things like a equivalent of a motivational interviewing pros and cons kind of thing in there, looking at the things that are in favour of their drinking and the things that are in favour of them stopping or reducing. And they can choose, of course, what sort of goal they're wanting to do. You might see on the right-hand side there that is the actual structure of our alcohol and depression program. And we call those steps the big ones with the like the making plans or first steps and so on. They're signposts, and then within those are the subsections. So people can jump around that and get into whatever they want to really very easily and quickly. However, if they just press next, they go through the program in a sequential way. Here's an example of clicking on a video which is describing keeping fun in your life, and as somebody who's taken up cycling in order to, as a pleasurable activity which is not involving drinking for them. This is an example of a late section in the program of looking at people's hopes and dreams for the future and things that they want to do. They do type in a small amount of text there, but it's linked to the icon, which is giving them categories. And then here's an example of a summary page. So we've currently got programs for alcohol and depression that is co-occurring. Depression with a focus on recurrences in depression, so we're not in the same space as mood, gym and so on. We're looking at people who are having recurrent depression and looking at trying to prevent those. Get Real is a really exciting one. This is on psychosis-like experiences, where people can test out their perceptions, and family and friends. And I should have said, by the way, through all of these, that these are accessible. If you look on the right-hand side for practitioners, you can all get access to all of these programs yourself by registering. And it's just a very simple process of agreeing to the medico-legal responsibility and giving your email address, and then you can be using that yourself with your clients or encouraging them to sign up. They're all free. The family and friends one is to support people, to support the supporters essentially of people with either alcohol or drug problems or mental health problems. And we've also got an app which we're just in the final stage of trialling at the moment, which is one of many apps that are out there for tracking drinking, but this one allows you to actually get into specifics about Australian alcohol and to be able to track the relationship with your goal. That's just a start though, and we're really quite excited at the plans that we've got for doing some much more interesting things using location and being able to look after your friends more effectively when you're in a drinking situation. Coming soon, we're going to be doing a drug diversion program very shortly for Queensland Health, just in the final stages of planning. That'll be motivationally oriented, and it's a support program for use by clinicians, but we'll also develop a client version. Say When is under production now for Victorian Department here for the Better Health Channel. That'll be a young person's been drinking one. Working with people from Menzies School, developing an Indigenous version of our substance use programs. Again, that will be just the early motivation and planning stages, and we're in discussion about the development of substance use tools for the CRC of Youth Health and Wellbeing. At the moment, as of last week, we've got more than 35,000 Australian visits over the first 20 months to our program. Like other people, like other programs and like our own work, they're not staying long on the site when they're just visiting and just dipping in and out again. But we have over 2,000 users, of whom 13, 14 are in alcohol programs, and they do come back to those when they're in the program. So as you can see, the number of logins is between 7 and 16, depending on the program, and the duration of use is fairly substantial. What do they use? Well, they tend to use the early phases. You need to read these in columns. The number on the left is a signpost, and you might have seen there were 6 signposts in that program that I showed you. And I'm only just going down to the top one, down to 50% of that. So it trails off quite dramatically, as you can see, after you get past the first or second signpost. So typically they're getting in there and using the early motivational and planning sections. They're not necessarily using guilt and shame and building friends and stuff like that. So they don't choose to do it all. And the question is whether they're wrong and we're right, we need to have all this stuff in there, or whether in fact they're right and we're wrong. And this is the early data that we've got on the alcohol program, just a pilot study. It was done by a student earlier this year. And it shows there that we're getting a time effect and men doing a bit better than women in this. By the way, we've got 60% women in our programs for alcohol. So it's it's the reverse of the gender balance we typically get in treatment context. But no significant difference between brief and full in that. No significant difference between brief and full in that either. Or we are getting something there, but it's in favour of men in the full doing best of all straight off. You might notice also that there's quite a substantial average number of drinks per week we're talking about here in this sample. More than we were getting typically in the snail mail ones, which were usually around 40, 44, coming down to around early 20s per week at the end of treatment. Our last correspondence trial was getting data that looked something like this, but even so, that's reasonably substantial. This is the people without depression in alcohol. For greatest reach in all of these programs, obviously you want to go for the internet only, because as soon as you add any kind of therapist contact, you're adding significantly to the cost. So community-wide programs ideally should be internet only. In the internet survey, we asked people what they wanted, and overwhelmingly they wanted a therapist. And that's consistent with what Dan was just saying. Only 19% of them said they wanted the internet only. And we got similar responses from the focus groups that Francis was involved with. So they're somewhat cautious and negative about internet treatment, saying it's impersonal, sceptical about the validity of the assessment and treatment, need for ongoing support. Positive comments about screening being able to be done online and the anonymity, but they said you need more motivation, and this is what consistent as well with some qualitative responses that came out of that students' research with the alcohol program. They said they really needed to have someone to make them accountable, keep them going. So, do they need it? We might expect therapists to be important. Alliance has argued to be really important in mental health care generally and in drug and alcohol work as well. But Jessica Brands and I have done a study looking at the effect of having a therapist, and there aren't enough studies to be able to do this just in alcohol and other drugs. So we looked across the board at the studies on internet with mental health or alcohol and other drug programs with therapist assistance that is higher versus lower. Lower sometimes means none. It sometimes means only a little bit, just a few minutes. Higher means, in each of these studies, a considerably larger amount. And that's what you get, an effect of 0 on adding a therapist. You can see there's only one study that's showing a significant effect out of that lot. So we are just completing the follow-ups at the moment on an alcohol and depression trial, comparing 3 conditions, just the first module, which had motivational interview style thing, including self-efficacy and building social support, concrete plan and goal, a full intervention with all the bells and whistles, and the full intervention plus a therapist who was in touch with them regularly by email, answering questions and assisting them with problems, because we can see what they're doing online. So assisting them with difficulties that they're having in working on the program. The emailed support was manualised in the sense that we developed a set of responses so we could be consistent in the trial and develop a form of fidelity with this, but we're trying to make sure that they are targeted to the person, they don't repeat themselves, and you can sort of select sentences or paragraphs to cobble together into these emails. and they were very, very positively received indeed, and people did feel that they were personal. And of course they're personally signed. But we've been looking at this, and at the moment we're still waiting on the final data, but it looks like we don't have a therapist effect in there, just like the review. We do have an effect very similar to what you saw in the alcohol trial with looks like brief is doing better than full initially. You're getting a faster effect, but the brief people catch up over time. So if a therapist is preferred by users, even if it's not more effective, can it actually help you in engaging people, right, and keeping them in the program? And the answer is yes. So in terms of that trial, the number of logins was considered, well, as you can see, it's still only 15, but 15 is quite substantial, a number of times to be getting people to come back if you've got a therapist. And they're actually, on average, finishing almost half the program if they've got a therapist. There's a question then of why the hell aren't we doing any better in terms of outcome? I guess, again, coming back to this issue that maybe you don't need the whole program to be effective. And doesn't that sound a bit familiar in the alcohol and other drug field? Brief intervention's often hard to do better than, isn't it? So we need to examine further whether this impacts on initial engagement, if it impacts on retention when they're going badly. Perhaps that would be really, really important to have a coach or therapist then. Maybe if their depression's really high, that will make it hard for them to keep going. We know that tends to happen with therapy. And we need to think about how we can actually improve the impact of these coaches or therapists. Probably better to think of them as a coach than a therapist in this context, because they're orienting them to the use of the program. And interestingly, not in this field, but in the work that Nick Titov has been doing at University of New South Wales, he actually finds that the administrative staff are as good, if not better, than the psychologists at doing this. And let's see if we can actually change the response that people have by marketing. So I don't see it as being a threat. I actually see it as being a promise that we can actually be doing something quite exciting in this space.